We've had quite a few people send in observations about patients that they've had who have admitted to some sort of sexual connection between their health problem and so on. And I suspect that if we've got a few patients who've admitted it, there must be an awful lot of other patients who probably haven't, because, as you say, it's a taboo subject. We don't talk about it. And Gary here says, I've treated 2 patients, both middle-aged men who'd seen previously. They were open about their sex-related issues. One who suffered headaches when he orgasmed, and another who suffered from low back pain, which he felt inhibited his sex life with his partner. And Gary says he actually felt privileged that the patients trusted him enough to share the issues with him. And I guess it is a privilege, isn't it? Because people are reluctant to open up about these issues. They must trust you to do that.
Yeah.
And they must, I suppose, hope that you have some suggestions. Orgasm and headaches?
Well, depends how good the orgasm is. Well, that might be a pressure to perform if it's the headache is
well,
maybe tied to it, or blood flow. I don't know. There could be all sorts of things going on there.
Yeah. Mrs. Trellis, Matthew again, says, in practice this can be a difficult area because it can so often be criticised after the event as of an issue of who has the power or is trying to get it. Actions taken in good faith can be later misconstrued as abuse of one form or another. It strikes Matthew that to deal with this proactively, we'd need to think a lot harder about what constitutes advance informed consent in these circumstances. Now, you're aware, I know, that we all medical practitioners will have to have informed consent for everything valid consent for everything we do, and maybe there's a difference, maybe there isn't. I suspect that and we say this on every show practically, I suspect that one of the key things is if we're going to have any conversation which could possibly be misconstrued, then we need to have it recorded in our notes pretty accurately, which is a shame because a lot of us write 2 or 3 lines in our notes which summarises the treatment, but if actually we've had a conversation about sex, we probably need to say exactly why it arose, what we discussed and what was recommended. And if anything untoward happened, whether it was a patient who ejaculated or somebody who came on a bit strong to a female practitioner, because there is a serious risk that patients make complaints, and if they complain that they think I spoke inappropriately about sex, then I end up in front of the General Counsel and it's their word against mine, unless it's in my notes and I've got a little bit of evidence.